talking about dislocated THR, 3 to 5% incidence over life of implant. On X-ray, look for the eccentric position of the femoral head as indicated as indication of polyethylene wear and risk of impending dislocation. Regarding the fractures influencing stability of total hip replacement, patient factors: female ratio male 2:1, soft tissue laxity and muscle weakness due to neurological injury like spinal stenosis, patient non-compliant cognitive dysfunctions, alcoholic, poor anatomy, revision surgery with compromised abductors and previous infection or trauma, greater trochanter advancement with placing abductors complex under tension, surgical factors, surgeon's experience, poor technique, prosthetic alignment, cup anteversion 15 plus minus 10, and 40 degrees plus minus 10 degree inclination of the acetabulum side. It's called Levenek safe zone. Aim of inclination should be 35 degrees. Stem anteversion should be 15 to 20 degrees, and combined anteversion should be 40 degrees. Coplanar test when base of the femoral head is parallel with the acetabulum. Increase surgeon's volume, reduce the hip dislocation. GIRF, get it right first time trial. Battaglia et al. South Korean study, posterior approach dislocation rate is almost equal to the lateral approach with careful posterior soft tissue and capsular repair. Soft tissue tension, abductor complex, avoid over-medialization of acetabulum, which Charlie used to do it. Tal will guide you for that. Femoral offset, perpendicular distance between the center of the femoral head and the line to the center of the femur, and acetabular offset, distance from the midline to the body of COR. Implant factors, arc of movement, the range of motion prior to the impingement. Native hip has a higher arc of range of motion than THR. Aim large head dash neck ratio. Excursion or jump distance femoral head must travel to dislocate. It is almost half the diameter of femoral head. Increase with large head. Use of lip liner, elevate rim. Use of face changing liner angled by 10 degrees in relation to the shell. Constrained liner, capture cup used for unrepairable soft tissue insufficiency. Limited range of motion, early loosening, wear, and exchange liner can happen. Whenever we see a dislocation, we need to classify it: early dislocation, intermediate dislocation, and late dislocation. Early dislocation is within 6 months. Non-compliance of post-op instruction, technical error, or malposition of component, impingement, retained cement, and faulty soft tissue repair should be excluded. Mostly managed with conservatively after reduction with abduction brace. Intermediate 6 to 5 years, older age, female gender, decreased muscle mass, predisposing factors like AVN and rheumatoid arthritis. More than 5 years, trauma, soft tissue laxity, neurological decline, age-related polywear, female gender, and weight loss. Regarding the workup, check the records, approach which was done, implant used and design, and the head size. In X-ray, I will check the vertical and horizontal offset, component position, acetabulum version, and inclination, femoral anteversion, and any feature of impingement. Management. Attempt close reduction under GA in OT, followed by checking check the stability. If successful, short period of immobilization and abductor brace for 6 weeks. If closed reduction fails, open reduction with assistance of soft tissue interposition in the sternum. Soft tissue tension is an important factor and exclude any impingement. Regarding shock test should be done, relative amount of motion achieved when femur is retracted away from the acetabulum, usually about 5 millimeter. Hip dislocations again or unstable, CT scan to assess the component position. If it's anteversion of the femoral stem or acetabulum component version, rule out infections and check for inflammatory markers. Intraoperative consideration if hip is not achieved. Resection arthroplasty is a last resort. Posterior lib augmentation device. Number in intraoperative if hip is unstable. Number one, PLAD, this posterior lip augmentation device. Number two, dual mobility cup. It combines two principles, Charnley low friction principle and increase head to neck ratio. Number three, capture cup or constrained prosthesis. Treatment strategy, if acetabulum is malpositioned, revise or rim augment. Femoral is malpositioned, revise. Soft tissue loss, trochanteric advisement, and constrained implant. Not defined, constrained implant. Defining the dual mobility works with two principles. The Charnley low friction with small head and Mickey and Farrar principle with a larger head for high risk patients. Regarding prevention of dislocation, identify the patient risk factor, restore offset large femoral head, restore leg length, and post-op care. Post-operative precautions does not impact early recovery. This is MCA multi-center trial 2019. So this doesn't prevent hip dislocations. Regarding question, if it's asked how to check the stability of the hip during the theater after total hip replacement, number one, shock test. Number two, measure leg length. Number three, check your short external rotators if you have lengthened or shortened it. Number four, stability in internal rotation and extension. If it's very difficult a question how to check the combined anteversion in OR, lift the leg up and see when the femoral component is parallel to the acetabulum component.